Well, Dr. Adrian Boyle is a consultant in emergency medicine and president of the Royal College of Emergency Medicine. Good morning, Dr. Boyle.
Good morning.
Have you seen anything like this in your career?
Yes, I have, but that goes back an awfully long time, and that goes back to the 1990s. But then we had, at the turn of the century, there was this enormous drive to fix these long waits, because this is all interconnected. The reason we're seeing these awful long ambulance waits is because our emergency departments are full, and in turn, it's because our hospitals are full. But going back 20 years, we were able, as a country, to turn this round.
That was because of the large injection of funds into the NHS?
Yes, but also the political will to establish things like the 4-hour access standard, the 4-hour target, which was a huge piece of work and took quite a long time to get going, but it emptied the corridors and actually pushed people through the system in a way that actually avoided all of these problems.
Okay.
This is a fixable problem.
Well, is it possible to fix without also fixing social care?
You're quite right. I mean, fixing this all starts at the back door of the hospital. And there's
discharges?
Yes, being able to use our beds properly. So at the moment, there's 13,000 people waiting in hospitals, about 10% of the bed base, who are waiting to be discharged either to home with a little bit more support or to a care facility. And that's just a massive own goal. We just need to reform the interface between acute hospitals and social care.
Okay, and that's not going to happen overnight, is it? I'm wondering if you can give us an idea, when someone like you and your team are in an A&E and you know that there are ambulances backed up outside, what happens? Do you go out to those ambulances and start treating people?
Yes, so essentially what happens is the ambulances become wards on wheels, and you know, it's not a great area for people to be waiting outside. The bigger problem are the people that the ambulance can't go to because it's stuck outside the emergency department. There's somebody lying on the floor or seriously ill or injured, and essentially not known what's going on with them. Those are the people who are most at risk.
The people who are still at home waiting for the ambulance in the first place.
Exactly.
Right. What's your view on these winter war rooms or NHS traffic control centres that have begun in about 40 different places? It's sort of essentially a way to use data and try and control where ambulances go and which hospitals they go to, essentially. Does that sort of thing make a difference?
So it's really too early to tell. You can analyse yourself you can paralyse yourself with analysis. It really is actually more simple and just about building increased capacity and making sure there's a workforce to try and look after these patients. These conditions, about these problems we're seeing with ambulance and emergency departments, they're markers of the whole system problem. And actually, once we start getting a grip of thinking about this as a whole system, we're not going to make any difference.
And do we know if outcomes are worse? It's clearly absolutely hideous and painful, as we heard from that personal account a moment ago, for someone to wait in pain in the way that lady's mother did. But do we know that actually the clinical outcomes are worse if people have had to wait?
Yes, so there's an emerging evidence base around this. So the Office of National Statistics each week reports excess mortality. At the moment, so last week we recorded excess mortality across all the United Kingdom of England of about 900 extra people. Now, there are lots of causes of this, but we think that problems with urgent and emergency care is probably contributing to about a quarter of this.
Right, that's a significant statistic and finding. Thank you very much, Dr. Adrian Boyle, President of the Royal College of Emergency Medicine.